If you don't look drop dead gorgeous with this filter.
Yeah, and they talk to the people and everything. Someone pulled that. Oh,
Alright, so you guys had the opportunity to go through the anatomy and physiology of the heart with Professor Bowling, correct? So we know that what's the heart? What's its structure and function? Somebody in the back row. Asia.
The function of the heart,
Yes.
pumps blood.
It does pump blood. And at what type, if the heart itself, what is it? It's a two-pump system, right? And it pumps blood to and from where? The lungs, good. And from where?
Body.
The body, correct. Okay. Good. And then when we think of our valves, we have 4 valves, correct? Yep. What are they?
Left atrium and right ventricle.
Okay, good. So did you hear her? Can you repeat it louder, please?
Right and left atrium on the right and left ventricle. Atrium on top, ventricle on bottom.
Good. All right. Then we have a cardiac conduction system. What is that? Like composed of?
It's the conductivity of the heart, so it provides the electrical conduction, like through the Purkinje fibers and whatnot.
Okay, so Purkinje fibers and whatnot. What are those whatnots?
The sinoatrial node and the atrial.
The AV node, the sinoatrial node. SA node is what? What do they also call that? The pacemaker of the heart, right? And that is located where?
The right atrium.
The right atrium. Then we have the AV node, right? And then what is it? Then it goes through the Purkinje, and through the bundle of his, right? His Purkinje fibers, and then causes contraction. Good. All right. So, thinking about the heart and the way it's set up, our left ventricle, it's that big muscular muscle. It squeezes and it pushes blood through our aorta, and then the blood comes out through the heart. But right at the base of the aorta, what do we have right there? The coronary. It's the start of the coronary artery, right? And that's what the coronary circulation is. So when you look at the aorta, right at the base, right above the heart, there's 2 vessels that branch off, and they become. Yes, ma'am.
You know how that's.
I know you don't. You do. You have to scroll down. It is slide number. Keep going.
22.
Yeah, slide 22. For the purposes of this lecture, I removed those ones just because you already went over it. I don't want to go spend the time on it. Okay? Yes? So, the right coronary artery feeds the right side of the heart and the right atrium and a little bit of the back. And the left coronary artery, there's 2 branches. There's a circumferential that wraps around the heart and goes to the back, feeds the back and the sides, and the left anterior descending, which feeds the front. And that is what, left anterior descending is what feeds the bulk of the left ventricle. Okay, and they also call that what? Have you ever, the LAD, or left anterior descending, is called we call it the widowmaker. Yes, have you heard that before?
Yes.
No?
No.
Okay, so the left anterior descending, it's the primary vessel that feeds the left ventricle. So if that one gets blocked off, how is my cardiac function gonna be? Good or bad? Bad, right? My left ventricle is the main chamber that pumps blood to where? My body. So if that dies, or if that becomes necrosis or damage from ischemia, from blockage, then guess what? A lot of people don't make it, especially if they're young. All right.
What was the name of that one?
Left anterior descending.
It's also called what?
The widowmaker. So when we look at the picture, now you can kind of see there's a right coronary and it kind of wraps around the backside of the heart. The left anterior descending comes down to the apex of the heart and feeds this whole area. And the left circumferential that kind of goes around, wraps around the back. Yes? Okay. All right, and then this is pretty cool. So now the new imaging that they have, they're able to kind of create a picture from x-ray of what your actual heart looks like. So this is an angiogram, and it's a reconstruction probably from a CT. Okay, so you can kind of see everyone has their anatomy. So when you think of people, their anatomy is a little bit different. So everyone's gonna have slightly different bifurcations and different ways that the vessel travels down, but it's gonna be very similar. And of course, there's also like just anomalies from genetics and stuff. All right. Okay. So we talked about the intrinsic conduction of the heart. So the heart has its own electrical system. So if you think of it, anything that messes up that electrical system, you're gonna see it on your ECG. And it gives an indication of how that area of the heart is functioning. You guys kind of covered that when you did the ECG dysrhythmias? Yes?
Yes.
Okay. Just really quickly, I just want to make sure you guys see this. So when you're looking at the ECG, this P wave is looking at see, it's a little purple here, and then you see that purple area up there. That's where that electrical impulse is spreading, yes? So this is a P wave, that's an SA node, it travels to the AV node. As it gets to the AV node, it's this little section right here, right? So, and then this QRS, this little down wave, is this electrical signal going ththrough the bundle of His and the Purkinje fibers. And then this last bit is the spread of the signal, and then right here is a squeeze. Yes? So if we see any changes right here in this little segment, that's gonna give us an indication of what? What's happening in where? Ventricle. So you guys see this heart? So what the atria are up here, yes? The bottom is the ventricles, yes? Okay, so you guys are seeing that kind of progression. That makes sense to you? Okay, and then this guy right here, this is just another depiction of that. So sometimes it's for people that like to see things in different ways, I just included it. But you can kind of see atria, kind of the electrical signal going to the ventricles, and then ventricle systole squeeze, and then this is the diastole, the relaxation. Yes? Okay. Okay, so atherosclerosis. So what, arteriosclerosis, what is that? I know I have the definition up here, but.
It's a hardening of the artery.
Yes, so it's an umbrella term. It's a hardening and stiffening of the arteries. And it can happen over time. And then in that subsection, there's something called atherosclerosis disease. And that is where it's an inflammatory process where plaques build up and they get into the intimal wall of the muscle, of the vessels, and create like a plaque. Over time, so basically what happens is that there's turbulent blood flow from high blood pressure, some sort of inflammatory process like diabetes, and it causes damage to the endothelium, the inner lining of the blood vessel wall. Yes?
It also can be caused for excess of cholesterol.
Yes.
So it's like when you use a pan and you don't clean it well, and it has a lot of oil, it eventually just keeps building and building oil. So it happens the same with the arteries until it forms like a plate, but it's full of cholesterol and
Right.
it clogs that.
So when those white blood cells are called to the area, they actually convert to some type of cholesterol called LDL, and they turn into like foam, what they call foam cells. The foam cells sit inside that, they create these little fatty streaks, and they build up within the muscle wall of the vessel. And as they build up, over time they harden, okay? And that hardening, sometimes it's so hard that they rupture, and then they create an opening, and then platelets come and they form a plug, okay? So I'm gonna skip this video because you know how well the videos work out on our thing. Okay, so this is kind of, atherosclerosis happens throughout your whole body, head to toe. But the main vessels where you'll see it is the carotid, the heart, and the aorta and legs. Okay, when it happens in the legs and the aorta, it's called peripheral arterial disease. When it happens in the heart, it's called coronary artery disease. And when it happens in the carotid, it's carotid disease. Does that make sense? Okay, so what are my signs and symptoms? What do you think of atherosclerotic disease in general?
Hypertension.
Signs and symptoms. So not cause.
Like third vision.
Okay, so that is where? Where would you have that? If I had atherosclerotic disease and I was symptomatic and I had blurred vision, where would I expect to see the problem?
The eyes.
In your,
That's
so your
what's in
carotids,
eye.
right? So actually that's a sign and symptom of a stroke is carotid disease, is that you end up having blurred vision or loss of vision in one eye because there's an artery that comes right off your carotid and feeds your eye. Okay, where else?
Short breath, right?
Shortness of breath, and what would that be? In your heart, coronary artery disease.
You're gonna have angina.
Headaches too.
So angina, so pain, right? And so if it's happening in my heart, I'm gonna have heart-like pain in my chest. If it's happening in my legs, I'm gonna have claudication or cramping in my legs, right, from ischemia.
You can also have like visceral pain that radiates to like your, usually the right arm or like the neck.
So, with, for us, if we have anything going on in our chest or our stomach, we have what's called visceral or referred pain. Okay, so it's not gonna be like someone's gonna walk in when I have chest pain and say, oh, you know, I have chest pain, it's this pressure and it's in my heart. Sometimes you can have different types of pain and it's called referred pain. So you can have pain that radiates to both shoulders, the arm, the neck, the jaw, the back. The feeling can be pressure, like someone squeezing, like kind of elephant on your chest, like something sitting on your chest feeling. But they also report like a burning sensation. Like, oh, it just burns. Every time I take a breath, it burns. Or my stomach. My mom had a heart attack, and she just said, you know, I have the worst like gastritis. And she's like, I had diarrhea. I just felt like my stomach hurt. She goes, and then she's just talking. She's all gray, and she goes, I just felt this. She was doing this with her hand, and I'm like, you felt a squeezing, Mom? And she's like, yeah, squeezing. And then I was like, oh, I think you're having a heart attack, but she was. But so that pain that people describe is very odd. It's different. It's not going to tell you specifically. But what else will you see?
A decreased level of consciousness.
Okay.
Because there is like a cut in the blood flow, and then you're not able to think
Right.
adequately.
So what am I lacking now at this point? What's going to happen to me? What's in
Oxygen.
Yes. So I'm going to become hypoxic, right? So I'm going to become dizzy, lightheaded. My level of consciousness, I might feel faint, right? And the other thing is my heart pumping effectively at this point? Maybe not. So how's my blood pressure going to be?
It's going to increase.
It's going to increase? Maybe
the
initially
beginning,
under
yeah.
anxiety, but then
And then-
the muscle's going to be damaged, so what's going to happen?
Hypertension.
It's going to go down, right? And maybe tachycardic. And then what else will you see? What else will you expect to see?
Diaphoresis.
Diaphoresis. First thing that you're going to do when a patient presents like that, what are you going to do? You're going to put them up to an EKG, right? And you're going to expect to see EKG changes. Yeah. Okay, good. So we kind of understand that. In general, so the thing about, if you look at atherosclerotic disease and coronary artery disease, there's two pathways. There's one that's like a preventative understanding of what's happening, maybe symptoms that are not life-threatening, okay? And the treatment bodes towards what?
Prevention. Of a heart
Prevention,
attack.
right? And then there's another line of treatment that goes to what?
Treating after.
Intervention. yes? So the first thing we're gonna do is if we recognize that our patient has any atherosclerotic disease is what?
Make it the
Diet changes, right? And we're gonna recognize remember our risk factors, modifiable and non-modifiable. What's a modifiable risk factor for atherosclerotic disease?
eating
Huh? Diet, smoking, what else?
Exercise.
Sedentary lifestyle, good. What else? Stress, excessive alcohol intake. How about hypertension? Is it modifiable? In a way, yes. Why? You can take medications, right? You can have a low salt diet. What about diabetes? Modifiable, non-modifiable? Modifiable, right? Because I can take my medications, I can follow up with my provider, I can manage my blood sugar, can avoid carbs, I can take the DASH diet. Yes?
Yes.
Okay. How about smoking? Okay, good. So when we do our education, we're gonna talk to them about that. We're gonna make sure, the other part is really knowing your numbers. So how will you know your numbers? You have to go to the
doctor.
You have to go to the doctor. You have to get your labs checked. You should be aware of what the numbers are. For LDL, in general, we want an LDL of less than 100, and an HDL above 40 for men and above 50 for women. Then the other thing is the healthy heart, healthy diet. They love to say the DASH diet, which is for hypertensive disease, or Mediterranean diet specifically. Basically, lean meats, high in fruits and vegetables, low salt. Become physically active, and physically active means 150 minutes per week. Okay, so it breaks down to about 30 minutes a day, more or less. And then quit smoking and vaping. Vaping is also bad for you. I know people are like, is vaping bad for you? I'm like, probably. In the beginning, it's like, we don't have any research yet, but it will be, right? And then know your HDL, and then lose weight. Weight loss of 10% can improve cholesterol. Weight loss of 5 to 10% can improve your cholesterol. And then smoking cessation. Smoking puts you at 3 times at risk of developing atherosclerotic disease than non-smokers. So don't smoke. Yeah, actually smoke, when you inhale toxins, when you smoke, you inhale toxins, and they create like these chemical mediators that produce inflammation and irritate the blood vessels. Right? So we talked about risk factors, modifiable, non-modifiable. Oh, non-modifiable, so genetics. A lot of people with history of coronary artery disease, you'll hear it that they have family history. Often it's associated with their cholesterol issues. Okay. So, and then talk about signs and symptoms, and then women will have atypical signs and symptoms of chest pain. So a 50-year-old woman that says she has really bad gastritis and it's really bothering her, maybe some pain in her shoulder, right? That's the one that you might want to investigate for acute coronary syndrome. All right. What does the other workup look like? So we're going to get a lipid profile. We may get a baseline ECG. And then if they have classic signs and symptoms of angina or some other risk factors, we may do a stress test and see how your heart responds to an increased demand. So stress test. Echocardiogram, and then cardiac catheterization is needed. We talked about all of this. Statins. What are statins? Give me an example. What? Not losartan. Okay. Losartan is what?
ACE inhibitors.
It's an ARB.
Yeah,
ARB.
I'm sorry.
An ARB. So if it ends in pril, it's an ACE inhibitor. Artin, ART is ARB. Okay. So not losartan, but statin, lovastatin, atorvastatin, ends in statin, right? Okay, so that does decrease your cholesterol level, but what they found is the use of statins overall increases longevity. People live longer if they take statins, regardless of what their LDL is. So depending on someone's risk factors, they may add a statin anyways. Yes? Okay. Blood pressure management, obviously, an antiplatelet therapy, so aspirin, clopidogrel. There's another medication called silastazol that actually is an antiplatelet medication, but also opens up your vessels. And then if you have angina, you may be prescribed beta blockers, nitrates, and calcium channel blockers, and we'll go over those in a few minutes. All right, so now that I have coronary artery disease, let's say I've done everything. I've had I've done everything I was supposed to do, take all my meds, and so on and so forth, but I have unstable angina, or I have angina that's still recurrent. You may need a procedure. Okay. So there's a PTCA, which stands for percutaneous transluminal coronary angioplasty, or PCI, which is percutaneous coronary intervention, which is the same thing. Okay, and what they're going to do, it's a minimally invasive procedure. We're going to watch a video, but they basically make an incision and they go through your radial artery or through your groin and go up and shoot dye into your heart and look at the vessels. Specifically look into the vessels of your heart to see if they're open or if they're closed off. At that point, if they see a blockage that they think they can expand through balloon angioplasty, they may insert a balloon and go into that narrowing of the vessel and kind of push it out. They'll keep the vessel open a little bit and they'll wait, and then they'll kind of smash those the atherosclerotic disease down against the vessel wall. Or they may go in and say, you know what, that blockage needs a stent. And a stent is this little meshy fiber, like a mesh straw that they put into the clot, and it springs open, it pushes the plaque open, or the vessel open. Okay? And then the last thing, if none of these are feasible, then they may do a bypass, which is also called a cabbage. Yes? Okay. This I'm going to do, hold on. I want to show you a video.
Barricone.
Okay. I hope you can hear this.
I want to talk a little bit about coronary angiogram for information of patients who might undergo this procedure. First of all, coronary angiogram.
Okay, so when you guys are watching this, I want you guys to think of what are your nursing interventions before and after. What are you going to be asking the patient? What history are you going to be collecting? What are you going to be assessing for after the procedure? Yes? Okay.
Is a type of x-ray picture of the arteries of the heart. You can see on our model of the heart right here that these red lines are the arteries, the tubes that take blood to the heart muscle itself. And as you probably know, these are prone to getting narrowed or blocked. And the angiogram is about looking for those narrowings and blockages. What we do in an angiogram is insert a tube through an artery in the wrist or sometimes at the top of the leg, thread it up to the heart, and then inject x-ray dye into these arteries here. The x-ray dye then outlines for us where the arteries are blocked. And based on what we find on those pictures, we then decide what, together with the patient, of course, what the best treatment might be. And various treatments include medications alone, sometimes bypass surgery, and sometimes the balloon procedure with the stent, which we call angioplasty, or these days we call it PCI.
How are you doing? Good. Okay.
On the day that we do the procedure, many patients come from home that morning, and if we're just doing the angiogram procedure, they usually go home the same day. It's an outpatient procedure, often home within a few hours. We usually ask you to not have anything to eat in the morning if your procedure is scheduled early in the day. If it's scheduled later, you can have a light breakfast before showing up. So here you see Mr. Nazim coming into the procedure room. He's being led to the procedure table. The nurses will do some prep of the skin on the hand and at the top of the leg. And then we usually insert some local anesthetic, a very small amount. A little bit of discomfort with that, but once it's numbed up, usually don't feel anything else. And you are awake during this procedure. We often use some mild sedation, so you're a bit relaxed, but we do not need a general anesthetic. You don't need to be asleep for this. In fact, many patients can watch on the monitor exactly what's going on. And following this, we proceed to insert what we call an introducer tube. The introducer tube is in place now. We advance the catheters towards the heart, and we are guided by the X-ray during this. You can see the people in the room wear X-ray protection in the form of a lead apron, and there are X-ray shields. This is mainly to protect the staff who are exposed to the X-rays constantly in their job. Here you can see we are actually injecting the X-ray dye and taking the pictures, and the images are shown in real time on the monitor. We're observing the monitor. We take multiple pictures from different angles. That's why you see the camera being moved around to different projections. Once we've seen the images, sometimes we will proceed with the angioplasty procedure, that's the balloon and stent, right then and there at the same time. In other situations, it requires further discussion, thinking about it, and as I said before, possibly other types of treatment. After the procedure, you're taken off the procedure table, wheeled back to the room, usually on a stretcher, sometimes in a wheelchair, and then we usually keep an eye on things and observe for 3 to 4 hours, sometimes a bit less if it's an uncomplicated procedure. And as I said, you go home the same day. We always ask you to take it easy that evening when you go home. But one of the advantages of this kind of procedure is you can get back to your usual activities very quickly. If we do the angioplasty procedure either at the same time or even if you come back for it on a separate day, that takes a bit longer for the procedure itself, and that depends on how complex your particular arteries and situation might be. We've completed taking the pictures and we're reviewing them now and discussing with Mr. Nazim what the best treatment option would be.
But at least one, but maybe two.
Okay, so what she's going to show her right now, I don't know if you guys can see it, but there's like a little narrowing right here. Okay, so you can see how robust the blood flow is right here, and then after there's some blood, but here it's kind of loses, it kind of grays out, and that's where the narrowing is.
Stents there, and that will probably make your chest discomfort feel better. And in this case, we all felt that an attempt to open that narrowed artery right away would be the best treatment option. So we're getting set up at this point to proceed with what we call an angioplasty or a stent procedure. We started working on the angioplasty at this point. We use a very fine guide wire which is threaded through the narrowed area of the artery, and then we insert a small balloon. Everything is very small here. The arteries themselves are only 2 or 3 millimeters in diameter. We insert the balloon and then we inflate it to stretch the artery a bit. That makes room to bring the stent in, and in this case we required more than one stent to fully open the narrowed portion of the artery. At this point we've completed the procedure, the stents are in place, and it might be quite obvious from the images that the artery is now wide open where it was severely narrowed before. At this point we just have to remove the tube, the introducer sheath from the wrist. We apply pressure over the site until the bleeding would stop. You can see that there really is very little blood loss, and the only incision made is about a quarter.
So here he's applying something called a TR band, and what it does is it applies pressure, manual pressure to the radial artery for a little while, and they're going to slowly but surely reduce the pressure on that to make sure that there's that you have a return of hemostasis. Okay.
Quarter of an inch in length. So you want to see the picture before and after? See, it's almost completely blocked. There's no blood getting through. And afterwards it's wide open. Lots of blood coming through. Okay? So that's called the right coronary artery. The bottom, it's the right and bottom part of your heart. And the whole bottom part of your heart was not getting very much blood supply. I think your angina is going to feel better.
That. Do you guys have any questions so far? So let's think about what are my interventions gonna be as a nurse? Prior to the procedure, what are you gonna check for? I forgot to do it.
Coagulation times.
So, one, we're coming into an artery, so what do we have to make sure? That they're off what kind of medication? Right? Right, and if they have any other bleeding tendencies, what's your next thing?
Allergies, because they're gonna.
Allergies to what?
The
The dye. And in older tests, you'll see that there's allergies to shellfish is also a concern, right? Not so much now, it's very specific to dye, but in older tests, and we are in the older test scenario, you'll have to also remember shellfish. What else? Consent, the consent sign.
About if they, like the time is gonna be, to see if the patient has to be like NPO for a few hours.
Right, how long they have to be NPO minimally for 6 hours before any procedure,
Don't they need someone to take them home?
okay? And make sure they have a ride.
I mean, besides the medication, we want to know their labs, right?
So bleed times, yes. Any concern for some type of infection, elevated white count, also cancels the procedure. Okay,
Should we do like AKG before the procedure?
they probably did. How about access? So right before the procedure, what should you be checking? Pulses, right, good, that they have a good, strong pulse, they have good blood flow, especially if they're gonna do a femoral access, you wanna check what? Pedal pulses, that has to be documented.
Like get a
Baseline.
of the patient, because you know, what if something messes up during the procedure and you're like, oh, I have no idea if this was like this before.
Right, so moving to that post-procedure now. So that's a good point. Why is it important to check distal pulses if we have a femoral access? What are we looking for?
That the blood flow returns after.
Yes, that we have return of blood flow to the leg, right? That would suck if we access the femoral groin to save the heart and we lost the leg, right? Okay, so,
Usually, like when we did our clinicals at San Francis after the procedure, every 15 minutes you have to be checking their vital signs, you have to be checking their pulses, peripheral pulses, and signs and symptoms for bleeding. And if it was like right in the femoral artery, they had to be like in a specific position. I don't remember if it was like I think it was a little. I don't remember, but they had to stay like that like for 4 hours.
for 4 hours. So in ATI, I wanna say that if you have a femoral access, it says something up to 6 to 8 hours. So just as a FYI, ATI says 6 to 8 hours, so maybe
6 hours what?
that you have to be flat for a femoral access. Why? What's so big about a femoral access? So she said signs and symptoms of bleeding. What kind of bleeding are we looking for? What are we looking for?
At the site, right?
At the site, theoretically, but now I've introduced a catheter and I've gone all the way up through the heart. So what could I do?
Internal bleeding.
Right.
Rupture something.
Yep. And so do you guys know where that blood sometimes goes? It goes it goes retroperitoneal. So you won't see it on the surface. What you'll see is it on the back, but the other signs and symptoms, what do you have if you have hemorrhage? Tachycardia. Okay, someone else besides Jeanette. Tachycardia, hypotension,
increased heart rate.
increased heart rate. What else? What will the patient look like? Do you know? Pale. How will they feel?
Lightheaded.
Yeah, it's lightheaded, dizzy, they'll feel anxious, right? Restless, they might have some pain. And then the other thing you can develop is a hematoma around the groin. Interesting enough, the femoral vessels, a lot of vessels run right alongside the nerve. So if I have a hematoma here, what else am I gonna have?
Numbers of the extremity.
Theoretically, yes, but what else? If I have sciatica, my nerve is being irritated, what is that? What's sciatica?
It's awful pain.
It's pain, right? It's very painful. So a lot of times if you have an aneurysm or pseudoaneurysm, what happens is the blood vessel tears a little bit, you'll end up with a lot of pain at the counter side. So you always want to assess for signs. So what are we assessing for? We're looking for bleeding and restoration of blood flow. So pulses, hematoma site assessment, and vital signs, and then general appearance and well-being. We're also going to make sure that we monitor the patient's back and make sure we look at their abdominal girth. Yes?
And
Mom?
it's true. We also check like the sensation at the sole of the feet when the patient came back. Well, before and after.
Before and after.
Yeah.
You want to get a baseline assessment because the worst thing to do is to find out that I didn't get a good pulse in the beginning and I don't know if we had good blood flow to that leg in the first place because what? I have coronary artery disease, atherosclerotic disease. Is there a chance that I have vessel disease somewhere else?
Yes.
Huge, right? Big chance. A lot of times when they do access, they'll go in and realize that they can't go in that way because the vessels are so tortuous. Nowadays, what you'll see is that they're really moving to radial access. Why do you think that is? What's better about going in the arm? Besides Janet.
Easier to monitor?
Easier to monitor. Mm-hmm. How about access-wise? What's easier to get to?
Your arm more accessible.
What's cleaner? Right?
And also the artery, like the femoral artery, is like bigger and has a higher chance of bleeding.
Sorry?
Don't need to be flat, like.
You don't have to be flat, so there's not the restriction of activity. Very good. And then also, it's also bigger and more chance of bleeding.
I have this procedure before in my childhood, but they did me here.
They did. They will
Yeah.
do. They will do radial. They will do here. If they do the radial, they'll look at it, and if it's bad, they'll try and see if it have a good access point here.
So they did cut and
Yeah.
put me some catheter to check my heart because I was born with murmur
Oh.
and my aunt she had had heart disease. So to be sure that I'm okay, I was like 8 years old.
8 years old?
Yeah, or 10 years old because we moved to another country like Hungary. My dad he was in the military, so they asked to do this procedure for me. It was okay.
How did you feel during the procedure?
I feel everything.
Yeah.
They give me just like a little bit sedation, and they told me, we give you just small shot, and I feel, small shot. You going inside, and I heard everything. They told me, oh, left ventricle, right ventricle. I was, oh, what's going on?
So you do hear everything. So what about during the procedure? What do you want to say? You want to be mindful of your patient, right? As nurses, the doctors, I can tell you the doctors don't care. They're going to do the procedure. They're going to get in and out. They're not really worried too much about their bedside manner. But on the nursing staff, we're the ones that we care about the patient. We're the patient advocate, right? So that's when we're talking to the patient, explaining them, were you anxious before your procedure?
Nope.
Well, you're a kid. So a lot of times there's some baseline anxiety or nervousness about the procedure because it's kind of fear of the unknown. They don't know what's going to happen, right? All right, let's go now. Moving on. Oh, I can't skip this. I forgot. I switched to the. Good job. You guys talked about potential complications. So this is actually, if you can see this is Turner's or Cullen's sign. So Turner's sign is this big hematoma on the back. That's retroperitoneal bleeding. And Cullen's sign is actually periumbilical ecchymosis that you can see here. And then you can see that this guy had a groin puncture. See that? There's a bruising around the groin. Right. So here, I have this lovely table, it's huge, right? That kind of discusses all the potential complications of hematoma. What are we gonna do? If we suspect bleeding, okay. At the groin site, we're gonna apply manual pressure. right? Sometimes it's old school, but sometimes they'll put a sandbag or like a pressure dressing depending on the site. If there's a TR band, which is the band that goes around the wrist, you deflate it little by little over 6 hours until there's this restoration of blood flow. Okay. And then we talked about it, tachycardia, widening pulse pressure, hypotension, decreased peripheral perfusion. You could have bruit at the insertion site. What's bruit? That's thrill. What's bruit?
You can just hear it.
You can hear it. It's like a swoosh sound. Whoosh, whoosh, whoosh. If you listen to it with a stethoscope, you can hear a swoosh.
Hear it for like, the patients that have like, that get, dialysis.
So that when you're doing dialysis, you hear that there's a connection between the arterial and venous supply, and so there's like a squish, but you can also feel like a frill. It like has like you can just feel it kind of.
Like vibration.
Yeah. No vibration. Thank you. All right, and then let's see what else. Arrhythmia. So now that we've messed with the heart, if there was any irritation to the muscle, the heart we can go into an abnormal rhythm. So we're going to be monitoring the EKG and or have them hooked up to a continuous monitor, right? And then we're going to treat based on the rhythm that we see. Thrombus, we talked about the pulse quality. Dopplers needed. They may need an antithrombotic agent. If we lose blood flow, that's one thing. So you'll have either cool or cyanotic limb, right? Decreased pulses can be thready, right? And then retroperitoneal hemorrhage, we talked about that. Typically, if we're concerned about a retroperitoneal hemorrhage, we're going to try. That patient's going to be in a lot of trouble, so we're going to actually give like an emergent blood transfusion, and then try and stop the bleeding. Okay. And then stroke. So the other thing that we're remember that aortic arch and the two carotids come off that great vessel. Remember this big aortic arch and two vessels that come across it. Anytime we mess with the heart or any of the vessels that are leading to the heart, the first area that can be affected if we dislodge a clot is what? It goes right to your brain, right? Because the carotids are coming up, the carotids go to your brain, they feed the arteries, and it can have a stroke. Actually, in these procedures, there's often little mini strokes that are not perceivable. Okay.
And when there is like the retroperitoneal hemorrhage, do they have to do like another angiogram to see which vessel is the one that needs
Yeah,
to
so then
be-
you call in vascular surgery in a hurry to take a look, in a big, big hurry. Okay, and the person goes right back to procedure. Okay, so you kind of talked about it. You guys did a good job. So we covered all of those things, excellent. Post-procedure, we talked about looking at the groin. So this right here, you guys just put a little X through this because I believe if you see this as a test question, it says 6 to 8 hours, not 4 to 6. Depending on what you read and where you read, this time varies. Okay. The other thing is if they have a specific closure device, some of those patients can go home within an hour. So it just depends. But if you're reading, if it's manual pressure, just imagine 6 to 8 hours. Yes, ma'am?
Oh, and you're gonna use ATI time, not that.
I have to.
Okay,
We're
just
using
wanna make sure.
ATI. You're using ATI to test, so I have to
okay,
use
I just
ATI
wanna
time.
confirm.
Okay? All right. So I think we did well. And then if you have a closure device, you obviously don't want them sitting in a tub or hot tub. And then when they go home, you're going to have them monitor their site for any signs and symptoms of bleeding or hematoma expansion. Yes?
What do you mean by closure?
They have these devices. There's something called AngioSeal. There's a bunch of different ones that actually mechanically close them. They put it in and it kind of holds the.
But they go inside or inside?
They're
Oh,
inside.
outside.
Inside. Mhm.
Ah, okay.
Yep. Yep. All right. Okey-dokey, let me go to the next slide. And then, we talked about this already, that we're gonna talk about numbness and tingling. we're gonna have them, we're gonna immediately notify if we have any of these signs and symptoms. So numbness and tingling, we're concerned about nerve damage or hematoma. Foot turning blue, we're worried about thrombosis. Infections, of course, anytime you do any type of procedure, you're always worried about signs and symptoms of infection, so you're gonna report those immediately. And then any signs of worrisome bleeding, so rapid swelling, bleeding from the puncture site that doesn't stop after you put pressure, any signs and symptoms of stroke or heart attack. 911. Okay. All right. How long have we been talking? 45 minutes. You guys want to take a 5-minute?
Sure.
Okay. I hope you guys are remembering that you open and remove mirror chest plate and get to your heart so they can reroute some blood. Does that make sense? So you need a surgeon. It's typically, they try not to do it, but they try and do it for patients who have obstructive disease, meaning that, so there's something called, oh my gosh, I can't remember what it's called. But basically, so I have prolonged decreased blood flow to an area. Let's say it's completely blocked. My body has created these little peripheral vessels to kind of go around and feed that area with blood supply and oxygen. But that tissue can be weak. That's called reperfusion syndrome. So if I, bless you, so if I resupply that area of blood, all of a sudden to weaken tissue might be too much force and cause damage. Bless you.
Sorry.
It's okay.
I swear.
Okay. So. But this is, so cabbage is typically, if you're completely obstructed, they'll do a bypass, or you have some type of contraindication to PCI. Maybe your vessels are not that well accessible because you have widespread atherosclerotic disease, maybe.
And if you're allergic to the contrast?
So depending, there are different things you can do if you're allergic to contrast. They can do an MRI type procedure theoretically, or if you're allergic to contrast, because they still need to do the angiography, right? They can do, sometimes they do sensitization, where they desensitize you to the contrast. So they'll put you in ICU, they'll give you small amounts, they'll give you Benadryl, like steroids, lots of fluids, and see if you can tolerate it. That I've seen. Pre-op, so always, you guys kind of, it's very similar. You're gonna sign for consent. You're gonna do blood work. They always want a chest x-ray. They probably want a baseline angiogram to know what the vessels are. Because at this point, they want to have been able to see the vessels to know what they're bypassing. Type in cross-match. Anytime you have a large surgery, you always want to type in cross-match, right? Because we're doing an incision, we're worried about losing a lot of blood, and we want to be able to give them blood. And then teaching. And then after every procedure post-operatively, you're always going to do vital signs every 15 minutes. Why? Because we just cut into the patient, we're worried about hemorrhage for the most part, right? You're going to give medications as ordered. When they have a cabbage, they come out with a chest tube and they go to intensive care unit. So you're going to monitor the chest tube for drainage. You're going to monitor all the incisions and do distal pulse checks. Then the typical monitor for lung sounds, turn, cough, deep breathe, I's and O's, make sure electrolytes are good, because remember with those electrolytes, especially which ones? Potassium and magnesium are very sensitive to the heart. And then we want to make sure they have due range of motion when they're able to, depending, to prevent DVTs. That's the same for every single patient that you have in a hospital bed.
When they're gonna get the angiogram or the PIC, do they get the type and cross match or not?
If this is for cabbage, you always get a type and cross match.
Just the
But-
angiogram
for the just the angiogram, they don't typically type in class.
and the PIC.
Don't, because it's minimally invasive.
Okay.
So they're not concerned at that point, even though there is a complication of like retroperitoneal hemorrhage and that kind of thing. It's a low risk. The risk is not completely out, but still the risk is a lot lower. Okay, so now we're moving on. So now we're going to talk about angina specifically, chest pain. And there are different types of angina. One is stable. That means, sorry, is there something you want to share with us, Josie? Okay, so stable. So stable chest pain is chest pain with exertion. Okay, my husband, for example. My husband also had a heart attack, as you guys know. So before he had his heart attack, he was telling me that he, he's always been a runner his whole life. So he'd gone away from it and went back, started running, thought that burning feeling he was having and that fatigue he was having after a run was just his being out of shape, right? But he had it, and then when he rest, it would go away. And it would only be reproducible when he ran, okay? Yes?
Do you mind me asking how old he was?
He was born in 75 and he had his heart attack last year. You do the math. 45. He was 45. So, interestingly enough, this guy, my husband, was told in his 30s, more or less, that he had high cholesterol, but he didn't want to take the medication, right? So he's going to do it with diet and take fish oil. And then his grandmother, his mom's mom, died in her 40s from what? Heart attack. And then grandfather, I don't know what happened to him. He died a lot. His side of the family is from Mexico, so I don't know what happened in Mexico. And then his sister, in her early 50s, guess what she had? Heart attack. So when we went to the doctor and he had his heart attack, he's like, I don't have a family history. I was like, what? I was like, look, what? Your grandma died and your sister had one. You have two direct relatives that both had heart attacks. Does he have family history? Yeah. So he had both of those. And then he had angina, but he didn't realize it. At the time, stable angina, okay? Reproducible with exercise, improves with rest or nitroglycerin. There are two forms of nitroglycerin, long-acting and short-acting. Which one am I talking about in this scenario? Short. Short. Long-acting is prophylaxis. Short-acting is this, right? I have chest pain, I have angina, stable angina, I take a nitro, 5 minutes later, I feel good. Yes? Okay. Unstable occurs unpredictably and does not improve with rest or medication. So what does that mean? I'm sitting in a chair, all of a sudden, I have chest pain. What does chest pain feel like? Burning, uncomfortable, feel short of breath, I feel dizzy, I have radiating pain to my shoulder, my neck, yes? Okay, I feel nauseous. Okay, unstable, happens unpredictably and does not improve with rest or medications. Then there's a variant, it's called variant vasospastic. Chest pain comes from cyclical and associated with activity and responds to nitrates. So that's like nitroglycerin, yeah? So kind of similar to stable, right? But it's really from vasospasm and associated with activity, okay? And then there's called microvascular, but we won't get into that. And spasms of microvascular cure of the heart. Okay, so out of all of these, which one is the most dangerous? Unstable. Which one needs treatment? Right away. Unstable. Yes? Okay. So in general, treatment of stable angina includes beta blockers. Beta blockers what? They reduce the workload of the heart. Okay, it is not necessarily for heart rate control or blood pressure control. Do you see that? So you can't always think, I have a beta blocker and it's for his blood pressure. If I hear that and I find out that he has angina, I'll be like, wrong, right? Because why are we doing this? We're reducing the workload of the heart. Improves exercise tolerance. You know why it improves exercise tolerance? Because it reduces the heart rate. So guess what? I'm working hard, but my heart, I'm not going to get super tacky, and I'm going to be able to tolerate that. And my heart's not going to be pushing against the blood vessels as hard. Calcium channel blocker, long-acting decreases, calcium channel blockers decreases contractility of smooth muscles and vasculature in vasculature and of the heart. Causes overall vasodilation. Again, what does that do?
More blood.
Right? Improves blood flow. Right? My heart's not going to be squeezing as hard, and my blood vessels will be more dilated. So that way, when I'm pushing, the blood it's like trying to push, I don't know, if you're thinking about a hose, right? So if you squeeze it, if you squeeze the hose, you're gonna have to really push, have a lot of force to get past the stricture. But if you have it wide open or get a big hose, the water just kind of flows through. Yes? Same. Okay. Nitrate relaxes smooth muscle. Smooth muscle is what? It's in the vasculature. Smooth muscle is vasculature. Okay, and for these patients, again, reducing the workload of the heart, but it also opens up the vessels of the heart itself. Patients who take nitrate should not use drugs for erectile dysfunction. They can have prolonged erection. It can be dangerous, and it diverts blood flow. And then vasodilation can cause headaches, but it improves over time. So this, I feel like, is a test question. This exact thing. Nitrates, vasodilation may cause headaches, improve over time. Okay?
Nitroglycerin is a nitrate.
Yes. The two, the long-acting nitrates are isosorbide, any isosorbide with a different monoxidine, whatever on the end, and then also nitroglycerin. Okay? Nitroglycerin long-acting, you're going to think of it in like a tablet or a patch. Short-acting, you're going to mostly think of it as a sublingual because you know why under your tongue is fast-acting or short-acting?
It absorbs faster.
Yeah, it absorbs faster because what? It avoids that first pass through your GI system. Okay? Skin is slow absorption. Right? Okay. So this is just a little picture to remember, right? And then look, so relaxes smooth vasculature, sublingual, so quick. This is gonna be quick. This is gonna be slow. So let's say I take some type of nitrate, maybe nitroglycerin, maybe isosorbide. Does that mean that if I have this patch on and I end up with chest pain, what should I take my sublinguals? Yes or no?
Say again?
That's correct.
If I have a patch on
Uh-huh.
and I have chest pain, should I take my sublingual? Yes or no?
Yes.
Yes. Yes. Right? Do I have to take my patch off? No. Okay, good. That is also a question, but I just want to make sure you guys understand that. It's just because you have this on doesn't mean this is contraindicated. This has an indication for what? Chest pain. This has an indication as prophylactic. Okay?
And how long do the patches last?
I believe you're supposed to take them off every 12 hours. So you have the patch on for 12 hours and you take them off. I have not seen nitro paste. I've not put out an ointment on anybody in years and years and years. But I heard at the VA they still use this. The ointment.
But if they have the patch and took the 3 doses of the sublingual and they still are in pain, then go to the hospital.
So if you take sublingual, so what, my other slide deck has it. So if I have angina, and my treatment is I'm taking all these medications prophylactically, but I still have chest pain after I went running. I sit down, I don't have any relief. Then I take a nitro sublingual, I wait 5 minutes, still have it, take another one, I still have it, I call 911. Okay, that's it. You get 2 doses and then you're calling 911. Okay? So for angina, for the short time, like acute exacerbation symptoms, whatever you're doing, you stop doing it. Stop. If that doesn't get better, you take your nitro. If that doesn't get better, you wait 5 minutes, take another one. If that doesn't get better, you call 911. Okay? Beta blockers. So beta blockers help the heart because it reduces heart rate, reduces the force of contraction, meaning that I need less oxygen to do that, and reduces the rate of AV conduction. And then the side effects, obviously, if I have too much, I can have bradycardia, lethargy. Sometimes they have GI symptoms. That's why you'll see that carvedilol has to be given with meals. You'll see that as an instruction. It can create congestive heart failure, decreased blood pressure, and depression. And then this is a mnemonic to remember calcium channel blockers, the different drugs. Very nice drugs. So verapamil, nifedipine, and diltiazem. Those are all calcium channel blockers. Okay? Blocks access to calcium from the cells, which decreases the contractility and the conductivity of the heart and the decrease for demand for oxygen, and then all the other things. If you have AV block, you guys talked about blocks in the ECG. If you have AV block, you definitely want to consider not giving both of these. Okay? Don't give them. Okay. All right. So acute coronary syndrome. This is an umbrella term, but it basically is the symptoms that you have when you have a heart attack. Okay? So, I'm going to have, what am I going to have? I'm going to have unstable angina, right? I'm going to have shortness of breath, chest pain, I'm going to be diaphoretic, I'm going to have radiating pain, whatever. I'm going to have gastritis, I'm going to feel dizzy. There's a feeling sometimes of impending doom or something's not right, right? It's typically associated with rupture of atherosclerotic plaque or complete thrombosis of the infarct-related artery. So typically these are acute. They happen all of a sudden. I was feeling okay 1 minute, then all of a sudden like, whoa, something's not right. Yeah? Because I just had that blockage right then, in that moment. Okay, and what you'll see is that you'll have either an ST segment depression or ST segment elevation. Remember, where is this? It's happening in my where? My ventricles, right? I'm not having good blood flow. There's some type of weird delay. This T inversion is that non-ST segment elevation. Sometimes you'll see a T wave. Sometimes it means old ischemia, but it can also mean new if it's a right infarct. Okay? So, my husband, chest pain, diaphoretic. Carol, I feel dizzy. Come get me from the gym. I should call 911. No, don't come. No, just come get me. Drive into the thing. I feel dizzy, diaphoretic. He's raising his arms to help him breathe. I put him in a chair. We go into the ER. Freaking security guard goes, chest pain? Because the way he looked. He was gray, he was diaphoretic, the way he was breathing. It was very classic. We went in there. I'm standing there. I'm looking at his EKG. And I'm like, that looks like ST elevation. So, oddly enough, he's like, can I have something to drink? I'm like, excuse me, nurse, my husband wants something to drink. She's like, oh, I don't know if I should tell you this, but I think you're having a heart attack. You can't, right? So, don't give him anything to drink. Okay. So, palpitations, signs and symptoms, right? Palpitations, pain described as squeezing, sometimes burning across the chest. So he was saying he had some burning feeling. My mom was saying gastritis, right? Neither one of them said chest pain. No, neither one of them said pressure in my chest, except my mom was doing this with her hand. Okay. Dyspnea on exertion. This should not say improve with rest. Well, it does improve with rest, but not go away. Okay. Diaphoresis, nausea, and decrease in any type of exercise or movement. They can have hypotension. They can have hypertension initially with the anxiety, right? Diaphoresis, pulmonary edema, right? At this point, maybe my heart's not pumping so well, so I'm getting backflow into my lungs, and therefore giving me JVD because I'm not having good cardiac return, right? So at this point, I'm getting congested because my heart's not pumping forward. right? It's getting backed up. Cool clammy skin, and you can have a third heart sound. All right, so this is just a chart. But so for unstable angina, so this is kind of like if you think about a TIA or something like that. At this point, if I have no cardiac damage, it's reversible. Whatever, we can try and fix this, right? If I have an MI, so at this point, I do have necrosis from microemboli, and now I will have some changes in my muscle. So at this point, the difference between unstable angina and MI, or myocardial infarction, is that something's infarcted. It says it in the name.
Mm-hmm.
Yes?
Yes.
Okay. So at this point, I have some type of necrosis, and I'll have increased biomarkers. So when my heart muscle gets damaged, it releases enzymes, and when I do a blood test, I'm going to be able to see those. So we do cardiac biomarkers, most troponin and CKMB. Those are most have the highest affinity for the heart muscle. Anytime you have damaged a muscle, in general, you can have elevation in any of these, but they are more specific to heart muscle. So I've had people with elevated troponins that just had a stroke and that's it. Okay, so it doesn't mean, oh, because you have elevated troponin, you have had a heart attack. You have to look at the full clinical picture. And then same, these two will be increased for a STEMI, non-STEMI.
And both of them are equally bad, the non-STEMI and the other one. The
It really depends. So STEMI is usually the left anterior, and NSTEMI is like a right-sided infarct. So not necessarily as bad. So going back to my husband, his right corner artery is occluded. It's already occluded. So he probably has had symptoms from that for a long time, but just didn't realize it. Yeah, but he was fine. It was only until the left anterior, his was the circumferential, left circumferential that was blocked. And it was only until then, that's when he started being symptomatic, like truly symptomatic. Okay, so it depends, and that's why one is called the widowmaker, right? Because they just die, so it is worse because it gives blood flow to the left ventricle than versus the right.
Okay.
Actually, I know a bunch of people that have had what they call silent MIs. Okay, so we talked about this, right? Infarction, area of ischemia. So typically what we have when we have an MI, it's like, oh, you don't want to just say forget it, because what happens when you have cell death is that right here the cells are dying, but that whole area of death can spread, and then you have decreased cardiac function. Yes? Yes. So we want to go in. We want to quickly recognize acute coronary syndrome and treat it, right? So onset, these are the things that you're going to ask. So you want to know when it started, what your signs and symptoms were, if it radiates, and it's typically not one spot, it's diffuse, and how long it's happened. Okay. This right here, diagnostic test. So we're going to always do an EKG. We're going to look for ST segment changes or T wave, and we're going to do these blood draws. Troponin, CKMB, and myoglobin. These times, so troponin, less than 0.2 is normal, so anything above that is abnormal and suggestive of MI, especially with chest pain. Levels arise rapidly in 1 to 3 hours of myocardial cell infarction or cell injury, and stays elevated for how long? 10 to 14 days, okay? This peaks in 24 hours. This one peaks in 6 to 9. You have to remember that. So what stays elevated the longest? Troponin. And that's the one that they typically look at the most, okay? CKMB and this, sometimes they look at it for other issues, but really that's the one we're looking for. Once they open up that blood vessel, you might actually, because you have more blood flow to necrotic tissue at that point, those troponins can rise up to very high, like 5. All right. So I come into the ER. I have chest pain. Immediately, from the front desk, wheel him right back to the back, right? Immediately. We're gonna put him on an EKG. We're gonna do a focused assessment, meaning we're just gonna see if they're having symptoms of heart attack. Yes? Then you have to think MONA. Morphine, oxygen, nitro, aspirin. MONA. That is a treatment for acute coronary syndrome, or MI. Don't forget it. Out of those four, which one do you want to give first? Morphine, oxygen, nitro, and aspirin. Which one first? So I would say nitro or O2, right? Yes?
I like O2.
O2 though, airway, breathing, right? ABCs. So if you have a choice, I would pick O2. Why? Because this person has ischemia, so we want to promote as much oxygen in their blood as possible. Okay, so MONA. The other things we're going to do is we're going to establish an IV because this person's probably going to go to where? Where do they have to go at this point? Surgery or where?
ICU.
No. They have acute blockage and we're going to try and run it and save it. How are we going to save it? Angioplasty, thank you. We're going to go to the cardiac cath lab immediately. Okay, so we come in, we call some type of acute STEMI. That's why it's important to call 911 when you have chest pain and you just don't drive yourself in, because those ambulance drivers, they call the hospital and tell them you're coming. And they take you to somewhere that can treat you. So you could go to, I don't know, try and show up at some place that doesn't have acute coronary intervention, and guess what? They're gonna ship you somewhere else. Right? So you wanna go, that's why you call 911 when you have a stroke and when you have a heart attack, because they're gonna take you somewhere that can treat you. Okay? So, but if this person walks in the ER, we're gonna try and do all of these things, right? We're gonna get an EKG, we're gonna do MONA, we're gonna do EKG. The only time that you don't give aspirin, you have to wait for a doctor's order, is if there's concern for a dissection, because you don't want to cause bleeding, excessive bleeding. Okay, so nitro, and then blood work, and then administer O2. Before you go to the procedure, they will give heparin, sub-Q, initially, because they want to get that blood flow back as fast as possible, and they want to break up that clot. Beta blocker, if not contraindicated, they may use IV nitro if you have persistent chest pain, and then you want to go to procedure. Okay. They typically they can, if you go to some place that doesn't have cath lab available, they may give you a thrombolytic. But honestly, all the history with thrombolytics show that it's not effective. Not that effective. Okay, and then this is just kind of another, what's this called again? Algorithm of what to do when patients come through. Okay. So look, less than 10 minutes, IV access physical exam, then you want to activate immediate general treatment, MONA. Right? Oxygen, aspirin, pain control, nitro. Yes?
So did you say it was oxygen first before nitro? Or nitro and then oxygen?
She said,
Let's do oxygen first. Okay? So ABCs first, because oxygen is going to be readily available at the bedside, right? You're going to be able to slap that on the person, and meanwhile, someone else is going to run and get the nitro for you. Does that make sense? Okay? So since I have this immediately, I'm going to give this first. And also it goes with airway, breathing, circulation. So airway, breathing, circulation. So circulation is the last of the things. So. Okay, so secondary prevention following MI. They're going to be on an antiplatelet agent, especially if they have a stent. If they have a stent, they use 2 antiplatelets. Okay, because now I have a foreign body in my body, and my body wants to clot that off. So I'm going to use 2 antiplatelets. Anticoagulants, if there's a thrombus, what's a thrombus? A big blood clot, okay? Or I have atrial fibrillation, or I have some history of, like some type of clotting history. So they could be on triple therapy for 3 months. So remember, when you guys are in the hospital, if you're seeing patients on 2 of these agents, there is an indication for it. There has to be a reason, or else we're putting this person at huge risk for bleeding. Okay. So if I hear that you're about to give aspirin and Eliquis, I'm going to ask you why they're on both. Does that make sense? Mm-hmm. And you should be asking yourself, why are they on both? ACE inhibitors, this reduces MI size, the size of the infarct, and it improves remodeling the heart, like recovery. Beta blockers, remember, reduces the workload of the heart. So they are going to be on these 2 medications, and their blood pressure parameters and heart rate parameters are going to be much lower. So typically systolic 90, on heart rate sometimes less than 55 to hold.
Oh, okay.
Right?
Okay.
So remember, the indication matters. Statin, regardless of lipid profile, at this point they've had an MI, it doesn't matter what their lipid profile is, we're going to give it. And then there are new anti-cholesterol medications out and new indications, but for now, let's just do that. Smoking cessation as needed. There's a lot of proof that giving Chantix actually improves the success rate of smoking cessation. They're going to do cardiac rehab. They're going to do the DASH diet or Mediterranean style diet, and they're going to optimize their risk factors. Let's see. Complications. You could have an arrhythmia afterwards. You can have a new reinfarction. You can have, so now at this point, if I have some type of necrotic tissue or my muscles damaged, I can have damage to the inside structures of my heart, or even a septal wall defect. Okay? This can also lead to a thrombus, because now I have dead tissue, and dead tissue tends to want to form clots. Okay? Inflammatory, you can have pericarditis, and then you can have shock, heart failure, TBA, MI, and other things. I've had patients that have had MIs, and then they shower their whole brain with a bunch of clots. Right? Okay. Cardiac rehab, it's just a program to get people back into exercise or get them started on exercise if they never did it. A lot of times they have the ability to monitor you, check blood pressure, do EKGs, right? It's in a hospital type setting, so for anyone that's anxious about returning to exercise, they know that they have the support of the hospital staff, so that's good. And then all of these other things, risk factor management. Okay, care plan, blah, blah, blah. Blah, 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 blah. Okay, blah, blah. Any questions? What time is our test? 2:45. What, huh? 2:45. I wonder if I could go earlier.
That would be nice.